All right, let's talk about airway management in cardiac arrest. There's been a pretty big shift in thinking with the new 2025 guidelines, and we're going to break down exactly what's changed. We're moving away from that old intubate early mindset to a compressions first approach, and we'll cover what that actually means for you on the ground. Let's dive right in.
And right off the bat, this quote really sets the stage for the whole conversation. The modern philosophy is crystal clear. It all starts with circulation. High-quality compressions are king. Now, don't get me wrong, airway management is absolutely vital, but it's a crucial supporting actor, not the main star of the show.
And this really puts it into perspective. Airway management isn't some isolated procedure we do. It's a key link in the chain of survival. It has to be woven seamlessly into everything else we're doing. High-quality CPR, defibrillation, post-arrest care, it's all part of one systematic approach to saving a life.
So let's build this from the ground up. Before we even think about reaching for a laryngoscope or an LMA, the guidelines are telling us loud and clear that we have to master the basics. Because honestly, this is where the magic happens. This is where most lives are saved. If there's one rule to burn into your brain, it's this one. Every single thing we do, every decision we make, especially about the airway, has to be seen through this lens. The question is always, how can I do this while keeping my hands on the chest and keeping that blood flowing? Because any pause, even for a few seconds, is a big deal. So before there's an advanced airway in place, this is the rhythm you live by, the classic 30-to-2 ratio. It's this deliberate cycle, right? It's designed to give you that critical perfusion from compressions, balanced with just enough oxygen from the breaths, all while keeping those pauses as short as humanly possible. And here's what's really interesting. The new guidelines put a huge emphasis on doing the basics perfectly. Effective BVM ventilation isn't just a bridge to something else. It's a critical, life-saving skill in its own right. A two-person technique is really the way to go to get that good seal. And notice the focus here. It's all about quality, not quantity. Gentle breaths, just enough to see the chest rise, and whatever you do, avoid hyperventilation. Okay, so you've got your basic BVM skills down pat. Now we get to that next crucial decision point. Should we escalate to an advanced airway? The new guidelines have really reframed this. It's no longer an automatic step, but a very careful clinical choice. And this is the big question, isn't it? For years, the default thinking was get a tube in as fast as possible. But does the evidence actually back that up as a universal rule for every single cardiac arrest? Well, the answer, based on some major reviews from ILCLR, is a resounding not necessarily. This is a huge takeaway. High-quality BVM ventilation can be just as effective as an advanced airway, especially in the early stages of CPR. Plus, it avoids that dangerous risk of stopping compressions for too long. This table lays out the thought process really nicely. On one hand, you might consider an advanced airway if the arrest was from an airway problem, like choking, or if you're in for a really long transport. But on the other hand, you should absolutely hold off if your BVM is working great, if you think the attempt is going to cause a long pause, or, and this is a big one, if the person trying just isn't that experienced with the device. So when you do make that call to place an advanced airway, you've basically got two main options: a supraglottic airway, or SGA, and endotracheal intubation, ETI. Let's see how they stack up based on the latest evidence. The choice between an SGA and an ET tube really comes down to the provider and the system. SGAs are awesome because they're quick, they're easier to place, and they're the go-to recommendation for places where intubation success rates aren't super high. ETI is still the gold standard for a definitive airway, but it's really for experienced providers in systems that can prove they have consistently high success rates. Now, this is important. The second that advanced airway, whether it's an SGA or an ET tube, is successfully placed and confirmed, the whole rhythm of the resuscitation changes. We ditch the 30-to-2 cycle and move to a whole new continuous flow. And this is what it looks like. We're now doing continuous, high-quality chest compressions, and someone is giving one gentle breath every 8 to 10 seconds. The key word here is asynchronous. The compressor never stops. This way, we maximize blood flow to the brain and heart while still making sure we're getting enough oxygen in. For you teams out there that do intubate, the guidelines have a couple of specific tips. First, video laryngoscopy is strongly preferred. The evidence just shows it improves your view and really boosts that all-important first-pass success rate. Also, just a heads up, the routine use of cricoid pressure is no longer recommended. Look, getting the tube in is only half the battle. What you do in the seconds and minutes right after is just as critical for survival. We're talking about confirming placement and then managing the patient once you get a pulse back. This is the one step you can never, ever skip. An esophageal intubation is a fatal mistake, plain and simple. The absolute gold standard for confirming that tube is in the right place is continuous waveform capnography. It gives you that real-time proof that you're in the trachea and ventilating the lungs. Now, once you get that return of spontaneous circulation, or ROSC, which is a great moment, the whole game shifts to post-arrest care. And if you look at the official algorithm, right at the very top, managing the airway and ventilation is still a huge priority. But now, our goals and our targets are totally different. After ROSC, it's all about protecting the brain and using a lung protective strategy. That means we have to be really careful with our numbers. We're aiming to avoid both too little and too much oxygen, so we target an SpO2 of 90 to 98%. And we want to normalize the patient's CO2, aiming for that sweet spot between 35 and 45. Okay, that was a whirlwind tour of the 2025 guidelines. Let's just take a second and boil it all down to the most important points that will probably change how you practice. So if you remember nothing else, remember these 5 things. First, compressions are everything. Minimize those interruptions. Second, get really, really good at two-person BVM. It's an incredibly effective skill. Third, think before you tube. It's a deliberate choice, not a reflex. Fourth, pick the right tool for your skill level and your system. And finally, always confirm placement and switch up your ventilation strategy the second you get a pulse back.
And that really leaves us with this final question to think about. It's a challenge, really, for all of us to take a hard look at our own protocols. Based on all this evidence, is it time we shift our culture away from intubate first and move towards a compressions first, high-quality BVM default? It's a critical conversation that every team should be having. Thanks for watching.